Good morning to everyone. I know that it's very early in the morning, especially for an Italian style, but I hope you will enjoy the presentation. First of all, I would like to thank the scientific committee to give me the opportunity to discuss with you this very important and unique topic. So the process of anti-cancer drug development is a multi-million-dollar and sometimes time-consuming business. In fact, from preclinical study to the completion of the phase 3 study and the achievement of drug approval requires more than 10-15 years. In particular, for colorectal cancer, the first evidence of preclinical activity of an anti-EGFR inhibitor was observed around 1984. The first monoclonal antibody approved for the treatment of metastatic colorectal cancer was obtained in 2004. Moreover, positive preclinical results are often followed by the failure of the drug in the clinical trials. The highest percentage of failure is observed in phase 2 study. In the therapeutic area, the oncology has the highest percentage of the failure, with only 29% of success in a phase 2 study and 34% of success in a phase 3. In the oncology area, colorectal cancer status is the worst because there is only a 3% overall drug approval. This suggests that the preclinical and all the clinical development process requires some improvements. So here we'll analyze the different preclinical models that can be used for drug development with particular attention of colorectal cancer. And we'll analyze the strengths and the weakness of each model. The first preclinical models was an in vitro model, which include cancer cells. Cancer cells are obtained from tumor tissue derived from patient, and they were the first preclinical instrument to test drugs. This is just an example how cancer cells can be used to investigate mechanism of resistance to anti-EGFR inhibitor in colorectal cancer. In our lab, we have generated colon cancer cells resistant to cetuximab. As depicted on the left side of the slide, you can see that MAP and AKT signals are constitutively active despite the inhibition of EGFR treatment. To investigate the mechanism of this resistance, a gene expression profile was performed and revealed that several genes that are involved in the MET pathway were activated in resistant cells. To investigate the role of MET in these resistant cells, we reduced the expression of MET by using a silencing RNA. As you can see, the reduction of the expression of MET restores sensitivity to cetuximab in resistant cancer cells. Moreover, the combined treatment of cetuximab plus PHA, that is a selective inhibitor of MET, results in an antiproliferative synergistic effect and almost a complete blockade of MET, MEK, and AKT pathway. So cancer cells can allow to do experiments that can be quickly and relatively inexpensive compared to the other models, can be used for drug screening and also, as we have seen, for genetic manipulation. Which are the weaknesses of this system? The weakness is that tumor cells' interaction with the stroma and the environment is missing. Moreover, also immune response is not possible to examine it with this system. And also the long-term propagation of cells in plastic dish may induce genetic and epigenetic change. To overcome this limitation, a second in vivo model has been developed. This is a Xenograft model. The first one was a subcutaneous Xenograft model. Cells are implanted in the flank of the immunodeficient mice to prevent the rejection, because we are implanting the human cells in mice. Tumor growth is followed by a caliper, and at the end of the experiment, usually mice are killed and tumors are collected for biological allogenetic analysis. So is this system useful for anti-cancer drug development for colorectal cancer? This is just a positive example. In fact, Prewitt et al. Have demonstrated that colon cancer cells injected subcutaneous to nude mice and resistance to irinotecan, the combined treatment of irinotecan plus cetuximab was able to overcome the resistance to irinotecan. These results were confirmed by a phase 2 study, the BOND trial. And based on these results, the combination of irinotecan plus cetuximab was worldwide approved for this indication. Unfortunately, this is only one of the few positive examples that demonstrated the role of these models as to prove the anti-tumor activity of the drug in human. In fact, there are several drugs that have demonstrated preclinical anti-tumor activity and that have failed to demonstrate any clinical activity in the treatment of colorectal cancer. This is just an example. A12 is a fully humanized monoclonal antibody against the insulin growth factor receptor 1. The treatment with this antibody induced a tumor reduction in colon cancer xenograft model. Unfortunately, these results were not confirmed by a phase 2 study in which the treatment of this monoclonal antibody alone or in combination with cetuximab do not have any clinical activity. Before considering whether or not the subcutaneous xenograft model can be used for anti-cancer drug development, there are several considerations that need to be made. I will not go through all these points, but just want to point your attention of the MTD. MTD is the maximum tolerated dose. It has been shown that MTD of the drug in mice is 4 times higher than in human. Gustafsson have demonstrated that the dose of vandetanib that should be used to have the same dose in men is 70.4 milligrams per kg daily. All the subcutaneous xenograft model use the dose of vandetanib that goes up to 150 milligrams kg per day, leading to a false positive results in the mice. So the use of very high and not clinical relevant dose for human is one of the major problems for this system. So this system is very simple and relatively low cost. The hosts that are mice are readily available, and statistic valid number of mice can be used. Unfortunately, the weakness is that the host is an immunodeficient mice, the stroma is rodent, and tumor usually grow in a non-natural site, that is the subcutaneous site. To overcome this limitation, a second in vivo model was generated, the orthotopic model. In particular, human colon cancer or cancer tissue fragments from the colon are implanted under the serosum of the mice, of the colon of the mice. And then colon primary tumor and metastasis are followed. This is a more clinical relevant tumor model with respect of the tumor side and the metastasis. Two questions are raised from this model. First, is the orthotopic site essential to achieve a clinical relevant drug response? And the answer is yes. Several groups, in particular Fiedler, have demonstrated that colon cancer injected subcutaneous do respond to doxorubicin, whereas all we know that doxorubicin is not an active drug in colon cancer patient. If we inject these cells in an orthotopic site, do not respond to doxorubicin anymore. The second question is the orthotopic site essential to investigate anti-angiogenic activity of the drug? And the answer is maybe. In fact, the anti-angiogenic activity of semaxanib was investigated by using intracolonic xenograft models. These results were not confirmed by phase 3 trial that was closed after the first interim analysis because there was no any activity of the drug. So, for sure, this model is a more clinical relevant model, but the weaknesses are that surgeries are often complex, and so we can use only a few number of mice per group. And is a very expensive model. Moreover, the mice is still an immunodeficient mice, and the stroma is a rodent, and sometimes tumor growth and the response are often difficult to follow. One of the major problems for the failure of the drug is the lack of preclinical models that can recapitulate the heterogeneity of the tumor. And to overcome this problem, patient tumor xenograft model has been developed. This model is very straightforward. Very fresh tissue from patient are directly implanted into the nude mice. The time to engraft is between 2 and 4 months, and the take rate is between 15 and 85%, depends on the human type. The histological characteristic of the PDTX model is retained, and so these histological characteristics are similar to the primary tumor. The problem is that after the engraftment, the stroma, the human stroma cells, are lost and are replaced by murine stroma cells. Moreover, also the genetic characteristic of the primary tumor are retained by this model. So because this model retains histological and genetic characteristic of the primary tumor, that is a directed tumor from patient, can be used for drug screening. Hidalgo has nicely demonstrated that there is a remarkable correlation between anti-tumor activity observed in PDTX model compared to the clinical outcome. In fact, in this PDTX model, the best combined treatment was irinotecan, cetuximab plus bevacizumab. The patient was treated with this combined treatment, and he achieved a very nice response that lasted more than 14 months. Another application of this model is to investigate the acquired mechanism of drug resistance. In 23 CRC PDTX xenograft were treated with cetuximab and then were analyzed for biomarkers to create a cetuximab resistance score. As we can see, the positive factor correlated to the cetuximab response were high level of activated EGFR and high level of epiregulin and amphiregulin. Negative factors were mutation Kras and RAS BRAF and high level of activated MET, HER3, and AKT. Another use of the PDTX model is to predictive biomarkers, to investigate potential biomarkers. Bertotti have demonstrated that in quadruple negative samples, so samples that have no mutation for Kras, BRAF, and RAS P3 kinases, some of these samples do not respond to cetuximab treatment. And the reason was because they found the amplification of HER2. Based on these results, the Heracles study was designed in which metastatic colorectal cancer patients that are resistant to cetuximab and have the amplification of HER2 can be treated with lapatinib and Herceptin. So, for sure, the PDTX model is a more relevant model because it retains the characteristic of the primary tumor. The weakness is that this system is very, very expensive, and also there are problems with the tumor engraft and engraft rate. This is the last in vivo model. That is a genetically engineered mouse model in which, through genetic manipulation, tumor can arise spontaneously into the mice. If you think colon cancer carcinogenesis, one of the first genes involved is the APC. So the first model had the APC mutation at the germinal line. Unfortunately, these mice with the APC mutation were supposed to die very, very early. So to overcome this limitation, another model has been generated in which the APC mutation is present only in the intestinal tract of adult mice. This is an example of how this model can be used for drug screening. In fact, dual inhibitor PI3 kinases mTOR induced tumor regression in this APC model that have no mutation of PI3 kinases. Another gene involved in colon cancer carcinogenesis is Kras. So, as the second model has been generated with the APC plus Kras mutation, the introduction of Kras mutation induced a tumor progression and also induced the formation of metastasis. Moreover, it has been shown that mTOR inhibitor can induce tumor regression only in mice that have APC mutation, but not in mice that have APC and Kras mutation. So for sure, this in vivo model, in this vivo model, the strangeness is that tumor can arise spontaneously into the mice, and the genetic event of tumorigenesis is known. One of the major weaknesses is the cost and the time consuming. To overcome this limitation, very recently has been published on clinical cancer research by Martin et al. They were able to generate what they called GEMM-derived cell lines. So, are murine cells that are derived from this mouse. These cells can be retain the characteristic of the primary tumor and so can be used for drug screening. Moreover, these murine cells can be injected into the colon of the mice and can induce tumor formation and metastasis. So these are the conclusions, and there are some consideration. In the 1998, an article published on New York Times said, "Mice are not men, and this is for sure. And if you are a mouse and you have a cancer, we can take good care of you." This was just to be provocative. We don't have a perfect preclinical model. Each model has its own strengths and weaknesses. So research needs to be chosen among the different models based on their specific goal. Thank you for your attention.